that I had a face-to-face meeting with about 4 years ago here at the Institute, but I knew about Dr. Mittal from her tenure at Syracuse, and Dr. Cooper Lovett says hello, by the way. She was here last night. And had heard a lot about her, and she left Syracuse. I never had an opportunity to meet her, and just by chance, when I was coming in to sit in on the Institute, we did a roundtable together. And so I really wanted to invite her to come in and speak with you all because she's doing some fabulous work in the area of HIV and IPV. So you have her bio. I'm not going to read that, but I think you're in for a treat, and I'd like to just present and turn the mic over to Dr. Mittal.
Thank you very much. Good morning, everyone. It's a pleasure to be here. It's been a while, so I'm really excited. I live very close by, so it was easy to come in as well. So I'm a faculty at University of Maryland. I'm in the School of Public Health. So as we were hearing, your anxiousness around what do we do, where do we go next, I'd be happy to talk with any of you later about my journey. So I am in the Department of Family Science, but I'm in a School of Public Health. I have a PhD in family therapy, but I also have a master's in public health. And so a lot of my research has been very, very heavily influenced by being in public health and really thinking about how do I integrate what I do and not just be in the fields of mental health, but how do I really make it about communities and really take mental health into the community in obviously my chosen areas of work. So hopefully what I talk about will be helpful in terms of how I took my PhD in family therapy, identified some areas of work that I felt like I wanted to grow in and develop expertise, and then develop an externally funded portfolio primarily through NIH money. Is this the, no, this couldn't be the clicker.
I think it's right here.
Ah, the clicker is right there.
Hold on just 1 second.
Okay.
Before you start there. I'll just leave this here for you.
Okay. So obviously this work would not have been possible without my mentors, my consultants, my research participants, my research teams, my clinical team. So I'd like to thank them before I begin. So a lot of the work that I present today is funded by 2 grants from NIH. One of them was a K Award. I can talk about those later if anybody's interested in wanting to pursue that, once you are at either a postdoc or an academic. And the second one is a current grant that I have from NIDA right now, and I'll talk a little bit about that. So really, as I mentioned, the focus of my work is really on the intersection between HIV and IPV. And the way I became interested, I was already a faculty at Syracuse University. I was doing regular academic jobs, but I had really always wanted to do a lot more research and develop evidence-based programs. So I was looking for a way and a mechanism to get out and be able to do that work. So I learned about, and at that point, you're all really lucky to have this space, I have to say. I wish when I was studying that I had access to something like this, because I had to do so much learning by myself, which you all have access to. People come and talk to you, present. It's really exciting. So I learned about a K Award, a mechanism through which you could become an independent scientist, but you had to propose some new areas of work. And obviously, through my accent, obviously I sound different. I'm not born here. I grew up in India. And one of the things that happened in about 2008 was a report came out by the UN, which said that India had the highest number of HIV infections in the world. And that blew me away because I had been living in India, I grew up in India, and that was not an India that I could really wrap my head around. So as I started reading more about HIV, because as a family therapist I knew nothing about HIV, I started learning much more about what puts people at risk. And one of the things that I could relate to and appreciate was that women's experiences of intimate partner violence significantly influence their risk for HIV contraction. So as I became more interested in it, I started reading more, I got hooked, and then the UN came out and said, oops, those numbers were wrong. We're taking back the projection of what we said. But it had given me enough time to really become interested in the topic and say, this is what I really want to do. So I think that was great. So a lot of my work, though, has been very US based. So I want to tell you a little bit about who's at risk for HIV in the United States, and then talk about the intersection between intimate partner violence and HIV. So as my figure shows that the HIV population among women in the US is 24% of the women in the United States. So women account for 24% of the infections of HIV in the United States. And within that, about 19% of new annual infections, right? So every year, 19% of the infections of HIV total are among women. And most of it can be attributed to heterosexual contact. So women are contracting HIV in the US because we're having sex with men. So that's the bottom line. In terms of age groups, as the figure shows, women between the ages of 25 and 34 in the United States are most at risk for contracting HIV. It's followed by women in the age groups of 35 to 44, then followed by 13 to 24, but those figures are changing drastically. Increasingly, we have a lot of younger, starting from adolescents into about 24, where the numbers are really rising. So further looking at who's at risk, really the data shows that minority women are at very high risk for contracting HIV in the United States. So women, Hispanic women and African American women make up about 25% of the population, of all women population in the US. However, they account for 79% of HIV infections among women. So you can see the health disparities. And if we break it down, in the United States, the likelihood of being diagnosed with HIV among black women is 1 out of 32 women in this country, black women, will contract HIV in their lifetime, compared to 1 in 106 Latina women, compared to 1 in 526 white women. So you can see, and this is really important, I'm taking this route because in order to do research, you have to find who's the high-risk population, right? And then you have to go in and make an argument about why we need to do something with this, and then two, as clinicians, what are we going to do about it, right? And I think we are at an advantage and a disadvantage. As clinicians, we're an advantage because compared to epidemiologists, biostatisticians, they only try to understand relationships, right? Well, how is this associated? What puts people at risk? But they don't know what to do about it, right? There's very, very few people who can say, this is what we need to do about it, or this is how we can approach this to make a difference. So that's where we're at a disadvantage. Where we, at an advantage. Where we are at a disadvantage, at least when I was studying, we did not talk about how to do funded research. Really, so this was uphill learning for me and learning on my own. We really need to figure out how to get a seat at the table. So a lot of you can think about positions as behavioral scientists. Even when we do our job search for postdocs or ultimate positions, I think we have very narrow lenses about where we can be, how to advertise ourselves. So I think that's really important to think. With our skills, we can really be at the table. We just need to learn how to sell ourselves better with the skills that you're getting in your doctoral program. So overall, let's talk about violence, which I think a lot of you may be much more familiar with compared to HIV. So the last big report that I know of in the country was a survey done by CDC in 2011. This was a really big national survey. Obviously, the definition of violence is physical, psychological harm, sexual coercion, efforts to control mobility, freedom, just some of the main domains that I'm capturing. In the US, approximately 1 in 3 women have experienced physical violence, rape, or assault by an intimate partner in their lifetime. That's very high. About 1 in 4 have experienced severe physical violence by an intimate partner, and 1 in 10 have been raped by an intimate partner. And I don't have the rates up there because we don't do a good job of asking about psychological abuse. And in my research, and in other people's research, when we talk about psychological abuse, the statistics are even higher. Because one, it's easier to talk about it, there's less shame. People can talk about it more easily and say, there's not as much stigma in being able to say this is what's happening, but these things are much harder to talk about. So what is the connection between these two, right? So as I was starting out early on, I had to do a lot of reading to understand. And I think the first big article came out in the year 2000. I clearly remember it was researchers from North Carolina, Chapel Hill, where they brought these two epidemics together. So we know that HIV is an epidemic in the world and in the United States, but so is intimate partner violence, right? It's really has tremendous health impacts. So the way you can see is obviously there is a direct relationship. If you could hypothesize, what do you think the direct relationship is about? Why do you think experience of violence directly increases women's risk of contracting HIV? Think of it's a sexually transmitted infection.
You don't have the ability to control any kind of contraceptive effort.
Correct. So the direct relationship is about being raped or forced to have sex when you don't want to. Think about sexual violence, right? And then you have, you're not using condoms as much. You're more likely also to have more partners if you are traumatized in ways that these women are. And also research shows that abusive men are more likely to engage in sexual risk behaviors themselves. So they are more likely to have sexual partners outside of their steady partnership, and they're more likely to not use any sort of protection in those sexual relationships. So they're bringing back more disease to the relationship, to the primary relationship. Hence, women's risk for contracting HIV is really high. But in addition, we're all mental health professionals, so we can appreciate what an experience of lifetime intimate partner violence or lifetime experiences of violence, right? A lot of the women that we work with in the community, violence starts very early on. It may not be in the form of an intimate partner. They've grown up in homes where they've seen their mothers being abused. They themselves report very high levels of childhood abuse. And then intimate partner relationships, abuse starts pretty early on in their relationships. And by the time I get them, even in their 20s, they've had a lifetime of exposure to trauma. So when you're exposed to trauma, not just exposed, but have experienced trauma over your lifespan, some things that happen put you at very high risk for contracting HIV. So some of these things are related to relational power. So you feel very small, right? So you feel like you can't negotiate, you can't talk about these things, you feel very vulnerable. Other things, severe mental health issues, right? Think about the days that we feel just sad and low, forget depressed, right? We don't want to do things that we know are good for ourselves. So imagine now, exacerbate that to feelings of depression, maybe having PTSD, severe anxiety. Are you present in yourself to have a conversation with your partner about your health? You're not thinking about those things. You're barely thinking about ways to survive the day and make it. Women who experience violence are at higher risk for having STDs. Biologically, if you have an STD, your body is much more vulnerable to contracting HIV. And you have other gynecological problems. You may have lacerations, which open you up more for HIV infections. The other thing is coping, right? So this is where substance abuse comes in, and it's a critical part of your training, is a lot of women use substances to cope with the trauma, right? So when you are engaging in substance use like drugs or alcohol, two things happen. One, it lowers your inhibition to engage in risky sex, right? You're more likely to move in the moment. And two, the other thing that happens is you are less likely then to think about, should I have a conversation about safer sex? Can I go have sex with a new partner that I just met? Or even in my established partnership, how do I negotiate things because I'm already too high? And sometimes it's not just the women engaging as a way of coping. Abusive partners, one way to abuse is also forcing women to engage in substance abuse. So that's another way that women get pulled into substance use. So once I knew about these direct linkages, I decided as part of my K award that I wanted to do something about this. So I actually decided I was going to develop an evidence-based intervention linking these two epidemics. So what does that mean? You know, we are all clinicians, and one of the things that I've always struggled is how do we know what we're doing really works? How are we assessing our interventions? And I think clinical psychologists have done this brilliantly, and that's why they're in the funding world, right? Where is a lot of the money going to? It's people who've been able to figure out how to evaluate their work and really show this makes a difference. CBT, you know, it has tremendous amount of evidence, but people have been able to figure out how to operationalize the constructs of CBT, develop an intervention on it, do pre-assessments, do the intervention, and then measure changes and long-term follow-up to say, yeah, CBT makes a huge difference in X, Y, and Z issues. So in the same way, I wanted to be able to develop evidence-based intervention. So it was a whole learning. I did a lot of coursework. This was part of my K, you know, not knowing. That's why I got a degree in public health, because I had to become more sophisticated in my statistical knowledge, but also in terms of developing clinical trials, because in the end, that's what I had to do. So the intervention, though, that I developed, I wanted to stay true to my MFT roots. So I don't know how familiar you are with transitional family therapy. In the field of substance use, you should be more familiar with this theoretical framework. It was developed by Dr. Judith Landau. She still does a lot of work. She was a faculty full professor at University of Rochester. She retired very early because she had found this incredible evidence-based intervention. And her career path was, if I'm stuck in the ivory tower, I won't be able to get this to the masses. So she left as a full professor, started her own company, has been doing incredible work ever since. So let me tell you a little bit about TFT if you haven't heard about it. And it's hard to read from there. It's basically an intervention that focuses on the here and now, but it really looks at intergenerational transmission of loss and trauma, right? So which is really important in the populations that we work with. So it takes contextual history, themes, stories, rituals, and really believes in strength, inherent resilience that people have, and really works on integrating people back to their family and culture of origin. The focus is really to understand how the trauma is transmitting across generations, and then works to remove shame and guilt, and really helping people understand that a lot of the coping mechanisms that they use are because of their experiences of loss and trauma that they have had in their lives, and helping people figure out, you know, what else could be different, what can they do differently. So one of the things that I use a lot, which I think a story you all possibly will relate to, it started as a joke. Somebody told me about it when they heard what I do, and I'll use that because that signifies TFT very nicely. So a woman was talking to her child, and they were in front of somebody else, and you know, the woman is asking the child is now a grown woman, when you make pot roast, why do you cut off the sides of the pot roast? I'm vegetarian, so I can't relate to the content of this, but I understand the meaning behind it. So she says, I don't know why I do that. My mom used to do it, so I just do it. So she says, you should go and ask your mom, why do you cut off the sides of the pot roast? She goes and asks her mom, so when you make pot roast, why do you cut off the sides of the pot roast? And she says, I don't know, your grandma used to do it. That's how I learned how to do it, right? And so many of us can probably relate to this story in our own lives as we think about it. So they go, luckily the grandma was still alive, so they ask her, you know, sometimes people die, so we don't have access to why something is transmitted across generations. So here the grandma was alive, and they asked her, so why do you do this? You know, we kind of do the same way. And she said, oh, my pot was too small. Right? So in her generation, it had a utility. There was a reason why she was doing something. But inherently in the subsequent generations, and here there's nothing negative about So just transpose that into something else, and the negative coping just transmits from generation to generation without us knowing, because we're totally cut off and we don't ask, or we lose people about why some patterns are continuing, right? So this was the really important family therapy piece that I brought to the intervention. The other two theoretical frameworks that I use are traditionally much more public health theoretical frameworks. One is called the IMB model, which is information, motivation, and behavioral skills model. So the idea really is to prevent or to reduce your risk for a health outcome. You need information about the disease. You need motivation to want to do something about the disease and your vulnerability for the disease. And third, you can have information, motivation, but if you don't have the skills, you will not be able to enact these, right? So that was the framework. So IMB says you need specific information about the health disease, but also cater to your group. So I had to think about heterosexual women, and particularly what puts women at risk for HIV. How do I help them have motivation to want to do something about their risk for both HIV and violence? And third is then teaching them skills. So that was one big theoretical framework. And the other one was the theory of gender and power, right? The IMB seems very clear, but as you can see, even in my nutshell, it's not very contextually driven. As a woman, there are many more influences on me, even if I'm not abused, that are bigger than who I am, to be able to influence my information, motivation, and skills, and how do I enact those skills. So the theory of gender and power gave a really nice contextual lens for me to be able to adapt the intervention and say, you know, these are not just women who are disadvantaged, they're doubly disadvantaged because they have experiences of violence. So I brought these three theoretical frameworks together, and I created an 8-week psychotherapy intervention. Okay? And it simultaneously addressed women's risk for HIV and intimate partner violence. And the goal really was to improve their health outcomes by reducing their risk for HIV and also reducing their experiences for intimate partner violence, right? Because they were already being abused by the time I got to them. So that's what I did, and I'll talk to you a little bit about how then I developed the intervention with the women. And this is an important piece of why I was invited to talk to you today, because oftentimes we conceptualize a lot of this within our own offices. So I'm not at the point of time where I'm translating this back and integrating into community-based agencies, because that is the main goal. But even in how we develop these interventions, you can really do community-based participatory research, CBPR, to really develop these interventions and get feedback from the time. Actually, I would say I used elements of CBPR. Ideally, CBPR is even starting with what are your main needs and beginning there. I already conceptualized IPV, HIV, interconnections, and then went to the community. Ideally, you should go to the community and say, what are your needs and how we can meet them, and begin there, right? Let me tell you a little bit about the intervention, and we'll talk a little bit about how I went about developing the intervention. So as I mentioned, I called my intervention Project Support, Supporting Positive and Healthy Relationship Intervention. So as I said, it was 8 weeks long. It had 3 individual sessions and 5 group sessions, about 2 to 2.5 hours long. We began with a 5-minute meditation exercise, and the individual sessions really were focused on the genogram. And we tried to go out as far as we could in developing the genogram. And the genogram was really looking at intergenerational transmission of unresolved trauma, loss, grief, family resilience, strengths, who had escaped and how had they managed to escape, and really learning from that, sources of personal supports and triggers, helping people understand the family life cycle, and really having a message, a recovery message, which was really a strong, powerful message for hope and change for the subsequent generations, right? That's part of where does motivation for change come from. We tapped into what we called family motivation to change. That I want to be different, I want to make different choices because I don't want my children to go through what I'm going through. Right? And that was really powerful for the women. The group sessions were really focused on STDs and HIV infection, intimate partner violence, really learning about it, safety and self-protection, and really working on choosing a healthy lifestyle. My control group, because in research, you really need to know a lot of things. But one of the things that you're critiqued on often is, how do you know these women didn't just change because you gave them so much attention, right? You're giving them time, you're giving them space, they can come talk about any number of things. Maybe it's just because it's a space that they've not had, which is a safe space. So you really have to think about, what are you measuring that against then, your intervention? So literally, one of the best ways to do it is you randomize women into two groups, and the other group gets something which is very different from what you're giving, but it has to match in time and attention, right? So those women are also meeting for 8 weeks. They're getting the same amount of therapy contact, and therefore you can say you controlled for exposure in terms of therapist contact, that probably did not make a difference. So we had to think of our control group, but ethically, I couldn't think of giving them nutrition information or some other information, because I knew that they are in very troubled relationships and are at very high risk for HIV. So what I decided was to have a IPV support group. And at that point, I was at University of Rochester in upstate New York, so I contracted with a domestic violence agency, because that's kind of the golden treatment, right? That's the best treatment that we have at this point for intimate partner violence, is send women to a DV agency. So the DV agency created a closed group support group for the women in my research that also met for 8 weeks, and there was a different topic each week around intimate partner violence. So some of them are, what is abuse, the cycle of abuse, impact of abuse on children, looking at grief, fear, guilt, self-esteem, personal rights, boundary issues, etc. So that's what the control group got. So this is, I don't have to spend time. Sometimes I have to show people what a genogram looks like, but you're all experts in that. So this is how I developed the intervention, really. This is where the women were really critical, and so were people in the community providing DV interventions. So I did a lot of formative work. This was a 5-year grant, so you can imagine the entire project took 5 years. It was not something that was easy. I could not have done it very quickly. The first year and a half really were about partnering with women, really understanding how do they see these issues. So as part of that, I did quantitative and qualitative data collection. With 112 women, I did assessments, so surveys. I have a lot of data, and then I did qualitative interviews and focus groups with a large group of women as well, to really understand what is the interconnection, how do they see the risk for IPV and HIV linking in their lives. What kinds of things would they like to see in intervention? I shared ideas that I had with them, and this is what I'm planning to do. Do you think this will be relevant? Is there anything else you want to see? Do you think women will come to an 8-week group? Because the group is as good as its participants showing up, right? I can develop the most fabulous group, but if people don't come, there's nothing I can do. So really picking their brain about, how do I get people to come? And these people have very chaotic lives and intense trauma. So when we get frustrated when client no show, this is the same thing, is figuring out and how I can preempt that or improve my ability to reach people, make them more comfortable, so we'll get more people to come. We also did a lot of assessments before the intervention began, and follow up for about 3 months after the intervention, because the whole goal is to see, was the behavior change sustainable, right? Because post-intervention, it's very easy. You have a high and you rate things pretty well. But you want to see at least some level of integration. So KWAT doesn't give you enough time. Ideally, in the research world, when you have really a good amount of money at hand, then you track people for 12 months to 24 months, because you really want to be able to say, this is evidence-based because the impact stays, right? Not that everybody goes back to their original way of being 1 month post the intervention. So that's what we did here. I had an intervention structure, I had these 3 theoretical frameworks, but we talked to the women, we analyzed a lot of data, and then we informed what we had. And then I did an open trial. So basically I did 2 groups. It's called open demonstration trial. No comparison group at this point, but I ran 2 groups concurrently of 5 women each. with my intervention, with the people that I had trained. So I hired clinicians to deliver the intervention. So a lot of training went into the model. And once they were trained and we felt that they could hit the ground running, we ran 2 groups, 5 women each, so 10 participants who met our screening criteria. And we just wanted to see if it was going well as we had anticipated, or what changes did we need to do. So once we did that, we additionally gathered more data from them. Then we refined the intervention. And then we went back and did a randomized clinical trial. Okay? So are you familiar with the term randomized clinical trial? Everybody? No. Okay. So randomized clinical trial. Okay. All right. So everybody's familiar, right? So then we did a randomized clinical trial. And the randomized clinical trial had 55 women. So it was not a very large trial, but enough for a K award to give us initial estimates of efficacy. And I'll talk to you about what I'm doing now with that. So overall, these are the 55 women. So they were recruited from many different places. Community-based agencies such as domestic violence agencies, but we really, in Rochester, had a very wide range of networks. I was at women's health organizations, hospitals, Department of Health and Human Services, even the court where women were there to take orders of protection. And it may not necessarily have been from their abusive partner, it can be order of protection from anybody. So inclusion criteria was pretty strict. The women had to be between the ages of 18 and 49. They had to self-report being HIV negative. They reported experiences of physical, emotional, or sexual violence in the last 3 months. They were heterosexual, so they were heterosexually active, and they had engaged in risky sexual behavior in the last 3 months. Now what that really means is that they have to say that they're not using condoms consistently in the last 3 months, but that's not enough. Many of us probably can relate to when we are in a primary relationship. Many of us don't use condoms in our primary partnership. So just not using condoms consistently does not put you at risk for STDs or HIV. The thing that's going to put you at risk is if in addition to that, you are having sex with more than one partner, or your partner is having sex with more than one partner, or you're having sex, unprotected sex with an HIV positive partner, or you're having sex with an injection drug user, or if you've had symptoms of HIV, of STIs in the last 3 months, right? So this is pretty stringent in terms of figuring out who's at risk for HIV. So we had to do all of those screening things, and finally we got 55 women. So this process of randomization really involved recruiting the women by screening them, telling them about it. Once they were recruited and completed screening, they did baseline assessments before starting the intervention, and then we randomized them. Then they were randomized into the intervention or the control group. It was 8 sessions long each. After the 8 sessions, we immediately did some post-assessments, the same measures that they had taken at baseline. They took it again at post-assessments. Then we kept in touch with them, and they came back 3 months later to do the same assessments again so that we could do change measures and analysis. So we ran about 6 groups, 6 phases like this, because we randomized 12 women in each phase, right? Because we had to randomize 55 women. So that takes a while to be able to do. So let me tell you a little bit about, we screened 204 women, and about 79 participants were eligible. So overall, that means 39% of the women that we screened were eligible. And imagine my screening criteria were pretty stringent, right? HIV risk and IPV, they had to meet both, and they had to be in a certain age range. And yet nearly 40% of my sample in a tiny, now I call it tiny because I'm here, in a mid-size upstate New York town, 40% of the women that I met were eligible. So the need is really, really high. So out of those, 55 women actually enrolled. So we lost, and again, remember that always happens. People will be eligible, they sign up for the study. but then when it comes to do baselines, they didn't show up. So we lost a bunch of people in that process. So ultimately, we randomized these 55 women who came for the baseline appointments. And once they were randomized, 27 of the women got the support intervention and 28 women got the control intervention. And then we again have some dropouts that don't come for post-assessments and 3-month follow-ups. Okay? So overall, you also have to do in research, given this is a pretty small randomized controlled trial, how do we know that things didn't improve just because the women who came to support were better off to begin with, right? So you have to make sure by analyzing some of the demographics of both the groups that they experienced similar levels of IPV, their HIV risk behaviors were similar, age was similar. So some demographics that you think that are key, you have to compare them. So we did group comparisons, and it's higher likelihood when sample sizes are so small that randomization doesn't truly work. Right, so it's even more important to do it. So actually, when we compared our groups, the women were different on some demographics. The women in support were slightly older, and these were statistically significantly different, so we had to control for them in our analysis. So women in support group were at average mean of 37 years old compared to 32 in our control group. They were more likely to be of other races compared to black or white. They were more likely to say they were married at some point in their lifetime compared to the control group. And lastly, they reported slightly higher income than the control group participants. So we controlled for all of these in subsequent analysis. Okay. All right, so in terms of who these women really were, so they were about 35 years old on an average, and that should be N of 55, not 133, I apologize. And overall, as you can see, about 30% of them had a less than high school education. They were primarily single, lifetime single. 53% had never married, 53% had married at some point in their lifetime. Majority of them were unemployed when we got them, 62%, and they had very low incomes, less than $15,000 they were making annually. And in terms of racial differences, 33% were white, 51% were African American, and 16% other, which is kind of upstate New York, Rochester demographics. Okay? So overall, this is really important to track in evidence-based interventions, is what we call feasibility. So feasibility, then you look at attendance and how long did people come from and how much could we retain people. So what I considered as treatment engagement was if people came for at least one session. What I considered an adequate dose of treatment is if they came at least to 5 or more sessions.